Delirium is a common condition. I'm going to tell you how I've come across delirium. So I've spent 30 years or more as a geriatrician in a large hospital in London, a university hospital in London called St. Thomas's Hospital. And in that hospital, we have, like all over the world, many acute, unwell adults, many older people. And we had specialist services for older people in the hospital. We would take patients directly from the emergency department or from the general practitioners, and we would look after those patients in our wards, but we would also be involved in looking after patients who are old and frail in other departments of the hospital. I'm going to give a fairly straightforward talk about delirium based on the literature and based on our own experience of many patients with delirium. So I will describe a little about its importance, the diagnosis, the causes, and then focus on what we can do to prevent delirium taking place, or probably more importantly in practice, reduce the effect of delirium. So this is a standard definition of delirium. I'll read it for our translator. Delirium is an acute, severe neuropsychiatric syndrome seen mainly in older people in hospital and associated with increased morbidity and mortality. So that's a general description. There are many previous names for what we now call delirium. People have used all sorts of words in previous years. Acute confusional state, acute brain failure, acute encephalopathy, etc. But so that we understand each other within our services and across the world, I suggest it's best to call it delirium and to use strict criteria set out by the Diagnostic and Statistical Manual, which I will describe in a few moments. Now, the reason why this is so important for those of us, particularly who work in hospital setting, is because of how common it is. So many surveys have shown that perhaps 1 in 5 or even 1 in 3 older patients who come to the hospital already have some features of delirium or go on to develop delirium during their time in hospital. For people who have operations, again, it's maybe a third of people, depending on the type of operation and the sort of person that needs it. So, for example, older people who have hip fractures are typically likely to get delirium because they are unwell people. The average age of a person with a hip fracture in our country is 83 years old. Another area is vascular surgery, where the majority of older people having vascular surgery already have some cognitive impairment. However, the commonest place in most hospitals for delirium is the intensive care unit. And of course, delirium is not uncommon as well in the last stages of life, in the last few days of life. Now, these are the diagnostic criteria that I mentioned from the Diagnostic and Statistical Manual, version 5, fairly recent. The cardinal feature is reduced attention, awareness of the environment. Typically, it has a fairly rapid onset, so the person is different from before, and it may fluctuate, so it may not be obvious on one visit to the patient. There are often additional disturbances, for example, perceptual difficulties, misinterpretations of objects or people, difficulties with language, memory, and orientation. And delirium, we think of, is not better explained by pre-existing neurocognitive disorder. That doesn't mean to say it's separate from that. It means that it's not only a pre-existing condition such as dementia from which it must be distinguished. And again, delirium, in this definition, excludes things like withdrawal from alcohol, delirium tremens. In this particular definition, it excludes that. It's to do with an acute illness. So just to repeat that, the clinical features that we might see: a quiet, withdrawn person, perhaps not doing very much, not saying very much, therefore very easy to miss. Perhaps it's that lovely little old lady in the corner of the ward making no difficulties for anybody, but without any idea what's happening. Delusions and hallucinations may give rise to agitation or distress or even anger, and these things can be noticed. Delirium, although it's a neuropsychiatric condition, obviously because it's a neuropsychiatric condition, affects behavior. And in fact, there is changes in dexterity. So the signature, for example, of the individual is quite different. And in fact, the abnormality of the signature of the patient quite closely correlates to the degree of abnormality of a clock drawing test. There are typically slow movements and disordered gait. So as somebody has delirium and then just begins to recover well enough to stand up, that is when they fall. These clinical features can be mistaken for low mood because of the withdrawal and the flat affect. So depression is an alternative conclusion that the nurse or doctor might reach. Delirium presents then in people who are very active, so-called hyperactive delirium, or people who are quiet and withdrawn, hypoactive delirium, or very often mixed. And individuals may move, in fact, from one type to another. As far as we know, there's no consistent pathophysiological difference between the types. Now, in order not to miss delirium, we need a systematic approach to recognition. And a widely used, although not very simple approach, was developed in the United States, and it's called the Clinical Assessment Method, or CAM. And this simply makes systematic what I've already described to you. 1, recent onset and fluctuating course. Therefore, you may need information from a nurse who knows the patient for 6 hours, or a family, or someone else. Secondly, impairment of attention. You may be able to test that by asking somebody to count numbers backwards. Those two, plus either disorganized speech or thinking, for example, delusions, or either sleepy, a reduced level of arousal, or a heightened state of arousal. So putting those together enables a confident diagnosis of delirium and is based on the DSM criteria. It has to be distinguished from dementia, which doesn't change day to day in a dramatic fashion, although it may coexist. And a particular form of dementia, dementia with Lewy bodies, can be quite difficult to distinguish from delirium because its intrinsic characteristic of changeability. I've already mentioned depression or disorders of language. So this slide sets out a number of the differences and distinguishing features. For reasons of time, I won't go through this, but we've agreed that our slides will be made available, so anybody who wants to have a look at this will be able to do so afterwards. So who gets delirium? I think it may be helpful to think of it in terms of those people who are likely to develop delirium because of what they were like before they became ill, the things that happen to an individual to tip them into delirium, and the things that make delirium worse or make it last longer. So predisposing, precipitating, and perpetuating. And here is a very simple model that I'll explain, and it's got wide utility for many geriatric syndromes. What it highlights is using big letters and small letters, that if there are many predisposing factors, for example, a patient who has dementia and malnutrition, it may take very little to precipitate delirium. For example, an infection that's not serious. On the other hand, if the individual has very little predisposing factors, perhaps someone in this room, then they may develop delirium only with a very serious illness. So, for example, the young person in the intensive care unit would be an example. Likewise, the severity of the delirium will affect how long it lasts, but will be varied by how it's perpetuated by things that the doctors and nurses and families do or do not do to help the delirium recover. So, the predisposing factors include dementia, which is the commonest predisposing factor, but also other factors, poor sight and hearing, which make interpretation of the environment more difficult, malnutrition and frailty. So the typical older patient with an acute medical illness who has multimorbidity is likely to develop delirium with a significant illness. The precipitating factors, here I refer you to a systematic review recently published of 11 studies. This compared the factors in patients who did develop delirium with the factors present in patients who did not develop delirium whilst in an acute hospital. And the medical illness severity was an important factor, infection particularly being important. Certain medications are important, and I will tell you more in a moment, but also things like sensory impairment, poor vision, instrumentation of the patient, such as urinary catheterization, dehydration, and electrolyte disturbance. So these are the factors, biomedical and social, that may precipitate the delirium. What medications are high risk? Well, in general, any medication which has an effect on the central nervous system is liable to increase the likelihood of delirium. But in addition, there are things that you might not be familiar with. For example, non-steroidal anti-inflammatory drugs and digoxin. Many drugs that we give without wanting them to be anticholinergics have anticholinergic effect. So if you add up the total anticholinergic load of many drugs given for many different purposes, that total amount is important in precipitating delirium. So therefore you need to know not the intended actions of the drugs, but the less strong unintended consequences which can add up. Now what is the pathophysiology? Well, I think the first thing to say is this is a syndrome, and there may be many different combinations of factors that can produce this common syndrome. So it may not always be the same. There are theories with evidence. For example, acute cortisol response to illness clearly does some brain damage. There's good evidence for that, both in humans and also in laboratory animals. And that probably produces immediate and lasting effects, which may prolong delirium and have longer-term effects. Secondly, it may be at the level of neurological function in the brain due to anticholinergic effect. Thirdly, there is evidence that inflammatory damage to glial tissue, which again is not really reversible, may be a factor in some patients. And in general, the higher the inflammatory markers, for example, C-reactive protein, in general, the higher, the longer the delirium will last. And finally, in some situations, hypoxia may be a significant factor. But you can see from what I've said that the mechanisms associated with those pathophysiologies are quite different. But in any one acutely ill patient, they may all be a factor. Okay, Now, this matters. For health services, this, just to remind you, delirium in our older medical patients is more common than heart failure, okay? That's how important it is. So we need to be aware of it. And the impact of delirium on people's illness, how long they stay in hospital, what happens to them, the risk of falling over, the risk of immobility and pressure sores, necessarily increases the resources the hospitals use and the length of time the patient stays in hospital. But for the patient, of course, it can also be a disaster. First of all, it's unpleasant. Those patients who are unlucky enough to remember their experience of delirium nearly always find it very distressing and often recall it as if it was a nightmare. The presence of delirium in most conditions makes it more likely the patient will die. And in the longer term, over half of patients with delirium still have some residual effects on their cognition, even 3 to 6 months later. Indeed, people who have an episode of delirium are more likely to develop dementia and more likely to die. Now, there may be several reasons for the relationship between delirium and dementia. First of all, does delirium make dementia worse? Well, that's a difficult one. First of all, delirium makes the cognition of the patient with dementia worse during the episode of delirium. But the question is, does delirium accelerate the pathological processes of dementia? Perhaps the best evidence we've got about that is from individual brain donor studies, which show that individuals with dementia who also had delirium certainly declined faster than people with dementia alone. But there was no evidence from that study specifically that the pathological processes of the dementia itself were worsened by the events of delirium. So looking at that in a bit more detail, does delirium cause dementia, or does it speed it, and does it even cause it? Well, again, a study based on brain biopsies, in fact, some of the same ones as the previous slide, showed that if the person had delirium, they do decline faster, they are more likely to develop dementia, but the neuropathological severity in the brain biopsies was not worse. Therefore, the mechanism of delirium causing the cognitive decline would appear to be additional to the dementia rather than simply speeding up the dementia. The practical outcome for the patient, of course, is the same, i.e., more likely to get dementia and more likely for the dementia to progress quickly. So on this schematic describes that course. So you can see, if you look at the green line in terms of function of an older person, you can see that that green line can be seen to start on the left and gradually decline for all sorts of reasons. But the red line describes the functional change of people with hospital admissions. So very often a reduction in functional ability during an illness in hospital, a recovery that's not quite complete, a continued path which is slightly worse than it would have been, with further declines and incomplete recoveries, each recovery becoming less complete, so that the cumulative effect means that that individual's function deteriorates. And delirium is part of the explanation for that sequence. Now, if a patient has delirium, how do you investigate it? Well, I can say very briefly, you investigate it in the same way as you would any acutely ill person. You might want to include things like vitamin B12 and folic acid, but essentially there's nothing specific in the patient with delirium that needs separate investigation. So, for example, a patient with delirium does not need a CT brain scan, does not need an EEG, does not need a lumbar puncture, unless there are other reasons to suggest that. It's a clinical diagnosis. What does need investigation is the underlying illness. Now, prevention. Can we prevent it? There are a number of studies. I'm going to refer to, and then pull together what the messages are. So again, if these slides are made available to you, you can pick up these references if you're not familiar with them. These studies had similar but not identical approaches. For example, the studies of Sharon Inouye often used volunteers to help orientate the patient on the ward, to help increase mobility, overcome sensory impairment, and also worked hard to reduce disturbance on the ward like noise. The work of Mark Antonioni with patients with hip fracture focused on a much more general, comprehensive geriatric approach. So what does it add up to? Well, if we pull it together in a systematic review, the multi-component interventions do significantly reduce the incidence of delirium by perhaps a quarter, which is worthwhile, maybe a third. And that's been shown in a variety of different types of patients and different wards, but also for people with and without dementia, which is very helpful. And as a result of reducing delirium, you also reduce falls, as delirium is the #1 cause of falls in acutely ill patients. And of course, if you reduce delirium, you're likely to reduce the progression of dementia and likely to reduce mortality, although the clinical trials have not been big enough to demonstrate that directly. So I'm going to summarize the main features about the prevention of delirium and reducing its impact. There is specific care that has to be given to an individual based on their specific characteristics. For example, correction of electrolyte disturbance or medication review. There are then general aspects which will be good for any patient in any case. For example, adequate fluids, increasing mobility, helping the individual to sleep, and helping the individual to see and to hear what's happening around them. But equally important, there are things that we need to do ourselves within the hospital setting, to do and to not do. So avoid physical restraint, ensure good lighting, be consistent in the approach that's used to the individual, help the individual to orientate with clocks, maybe a calendar, with simple reminders. Hello, this is Tuesday. Is it? No. Hello, this is Thursday. It's April the 19th today. We met yesterday. Doesn't matter. You've seen many people. I remember yesterday we did this. For example, do not expect the patient to remember that you saw them yesterday. For the patient, every moment is a new moment without necessarily reflecting the previous moment. So therefore, assuming familiarity is not a good idea. So there are things, therefore, that's specific to the patient's illness, that are general for any patient, and things as institutions we need to get right. So, for example, we need to address pain, medications, hypoxia, sleep, sensory deprivation, mobility, and then treat things like infection. Now, the next 3 slides I'm jumping because, again, they will be available and they give a little bit more detail about the 3 areas I've mentioned. Optimizing the person's capability, making the environment helpful, and reducing the challenge that you present to the patient, i.e., keeping the treatment simple. Don't argue. Okay? Don't do things today if they're not really necessary. These are the things that make an individual more likely to recover from delirium and less likely to be distressed while they have delirium. What about medicines? Medicines are the last resort for patients with delirium, but are sometimes necessary. Specifically, it may be necessary to sedate a patient in order to do investigations which are essential for that patient's diagnosis and recovery. Many investigations are not. To prevent injury to the patient or someone else, or to prevent severe distress. The medications that we use include haloperidol, because it has less anticholinergic effect, starting slow, but reassessing frequently, i.e. every couple of hours, and gradually working up. Of course, we would not use that in patients with Parkinsonism for whom benzodiazepines are the better alternative. I just want to focus finally now on just some of our local experience in St. Thomas's Hospital. This is a hospital approach to preventing delirium. And this relates to a general theme of how we have to go forward. We have to have health services that are not surprised that the patient in front of them is old and frail. Not surprised if the patient is liable to have delirium. It has to be embedded in the ethos. So increase awareness of delirium. So for example, in our hospital, we've addressed the awareness and recognition of delirium in two simple ways. One is all members of staff in the hospital at every level, clinical, managerial, administrative, porters, everybody, have been obliged to sit and watch several videos about a woman called Barbara who had dementia. And the video takes that person through a clinic, an award, and investigations, and highlights the experience of someone with dementia, making everybody in the hospital dementia cute, to understand what does this seem like for someone with dementia. So recognizing and expecting dementia is everybody's job. And secondly, think delirium. Is your patient confused? Think delirium. So raising awareness. Secondly, we try to keep it simple but systematic in terms of this, for example. We have this given to every junior doctor and nurse, and it sits in their lanyard. For patients with delirium, on the green side, these are the things you must do, and on the red side, these are the things you shouldn't do, and on the orange side is, these are the drugs you're going to use. No guessing, please. This is what you do, and this is how you do it. So simple and systematic. And finally, we have a specialist team for those individuals who are proving difficult to help. So a specialist team which can be drawn to any part of the hospital to focus on persisting delirium or dementia. Thank you for your attention.